All right, today we're diving deep into the cholinergic system. This is the intricate network of chemical signals that's, running the show behind the scenes, controlling everything from the beat of your heart to the focus of your eyes. It's a fascinating story that involves historical mysteries, powerful poisons, and what seemed like miracle cures. Let's get right into it.
Our story starts with a real puzzle from way back in 1644. Picture this. Virginian settlers capture the renowned warrior Chief Opichenkanov. They're expecting a formidable leader, but what they find is something else entirely. A man so weakened he can't walk, so weak he can't even open his own eyelids, and nobody knew why. It was a complete mystery. Now, let's jump forward nearly 300 years to 1934. A physician, Dr. Mary Walker, sees a patient with those exact same symptoms. And she has this brilliant hunch. She thinks, this looks a lot like poisoning from tubercular, which is a paralyzing agent. So she takes a leap and gives her patient a drug called physostigmine. The result? Absolutely astonishing. Within minutes, the patient is up, walking around, but the medical community, they were skeptical, to say the least. They basically laughed her off. A recovery that fast just seemed too good to be true. So these two cases, separated by centuries, hand us our central mystery. To crack this whole thing open, we really need to answer 5 key questions. First, how can a poison and a disease cause the exact same symptoms? Second, what's the secret behind this so-called miracle drug, physostigmine? And from there, we'll explore what else these powerful substances can do and what we have to watch out for.
Okay, so here's our game plan. We've got our 2 patients, our mystery. From here, we're going to build our case from the ground up. We'll map the nervous system, understand the specific chemical message being sent, and meet the receptors that hear that message. Once we have all that, we can finally figure out how to block or boost the signal to solve our mystery. And then we'll zoom out and look at the bigger picture.
First things first. Before we can get into drugs and diseases, we need a map. We have to understand the body's fundamental wiring, the nervous system itself. This diagram here gives us the perfect bird's eye view. At the top, you've got the whole nervous system, right? It splits into 2 main parts. There's the central nervous system, or CNS. That's easy, it's just the brain and spinal cord. Everything else is the peripheral nervous system. Now, that peripheral system splits again. You have the somatic system, which is for all the stuff you control consciously, like moving your arm. And then there's the autonomic nervous system, for all the automatic stuff, your heartbeat, digestion, you name it. And finally, that autonomic system has 2 famous divisions, the sympathetic, which is your fight or flight mode, and the parasympathetic, your rest and digest mode. Oh, and you see that word ganglion on the chart? Don't let it throw you. It's just a fancy term for a junction box, a place where nerve cells connect outside the brain and spinal cord. So let's zoom in on those autonomic nerves. The first nerve cell that leaves the spinal cord is called the preganglionic neuron. In the sympathetic system, these neurons start in the middle of your back, they're short, and they branch out like crazy, talking to lots of other neurons at once. It's like a broadcast system. The parasympathetic system is totally different. Its preganglionic neurons come from the very top and very bottom of the spine, near the brain and sacrum. They're really long, and they usually make a single, direct, one-to-one connection. It's more like a dedicated phone line than a broadcast. And these differences in wiring are absolutely key to how they function.
Okay, so we've got the map, we know the wiring. Now, what's the actual message being sent down those wires? Well, the star of our show is a neurotransmitter called acetylcholine, or just ACH. We need to understand its whole life story, from beginning to end. So the journey of acetylcholine has 4 really critical steps. First, it's made, synthesized, inside the nerve cell from a couple of building blocks. Second, it gets packaged for storage. Now, ACH has a positive charge, so to keep it stable, it's bundled up in these little bubbles called vesicles, along with some other molecules that neutralize it. Third, when it's time to send the signal, the nerve releases these vesicles in these neat little packets called quanta. And fourth, and this is maybe the most important step for our story, the signal gets shut off. An incredibly efficient enzyme called acetylcholinesterase, or ACHE, swoops in and breaks down the acetylcholine almost instantly. This rapid cleanup is what allows for precise on-off control.
So, the signal, acetylcholine, is launched across the gap. But how does the cell on the other side actually hear the message? That's where receptors come in. They're the ones that catch the signal and turn it into an action.
And these receptors come in 2 main families, 2 different flavors. First, you have the muscarinic receptors. These guys are a bit more complex. They're called G-protein coupled receptors. When they get a signal, they kick off a slower, multi-step chain reaction inside the cell. There are 5 types, M1 through M5.
The other family is the nicotinic receptors. These are much more direct. They're basically little gates. When acetylcholine binds, the gate just pops open, ions flood in, and you get a very fast response. There are two main subtypes here, NN for the ones on neurons and NM for the ones on muscles.
So let's get specific about what these muscarinic subtypes do. M1 receptors? They help with things like ramping up stomach acid. M2 receptors act as the brakes on the heart, slowing its rate and making it beat less forcefully. M3 receptors are the real workhorses. They make smooth muscles contract, like in your gut or bladder, they trigger glands to secrete things, and they can even make your blood vessels relax. The M4 and M5 types are mostly found in the brain and central nervous system, and we're still figuring out all their jobs. Okay, we've laid all the groundwork. We have our map of the wiring, we know the signal, and we've met the receivers. Now, with all of this in our toolkit, it's time. Let's go back to Chief Opachenko and Dr. Walker's patient and finally solve this mystery. That critical connection point where a nerve tells a muscle to move, it turns out you can block it in two main ways. The first is with what's called a non-depolarizing blocker, and this is exactly what tubercularity is. It's a competitive antagonist. The best way to think of it is like a lock and key. Tubercularity is like a key that fits in the lock, the NM receptor, but it won't turn. It just sits there, physically blocking the real key, acetylcholine, from getting in. The result? The muscle can't get the signal, so it goes limp, a flaccid paralysis. The second way is really interesting. A depolarizing blocker is actually an agonist. It stimulates the receptor, but it doesn't let go. It just keeps stimulating it until the receptor gets overwhelmed and just shuts down, becoming desensitized. Okay, that explains the poison. But what about the disease myasthenia gravis? Well, it's an autoimmune disease, which means the body's own immune system gets confused and attacks itself. And what does it attack? It creates antibodies that go after and destroy the nicotinic NM receptors on the muscles. And this is the aha moment. This is the link. It doesn't matter if your receptors are being physically blocked by a poison or destroyed by your own body. The end result is identical. Acetylcholine can't deliver its message, the muscle can't contract, and you get that profound, debilitating weakness. So how did physostigmine pull off that miracle recovery? It all comes back to that cleanup enzyme we talked about. Physostigmine is an acetylcholinesterase inhibitor. It works by taking out the cleanup crew. So now, when acetylcholine is released, it doesn't get swept away. It hangs around in the synapse for much, much longer. The concentration builds up, and it's essentially shouting the signal instead of whispering it. This super-powered flood of acetylcholine can then stimulate whatever few working receptors are left, and that's enough to get the muscle working again. It's not a cure, but it's an incredible way to boost the signal and punch through the blockade. So, mystery solved. But this is way bigger than just these two cases. Now that we understand the system, we can explore the whole pharmacological world that targets it. All the different drugs that can either mimic acetylcholine or block it for therapeutic effects. Just take a look at this table. These drugs are all designed to look and act like acetylcholine, but with a twist. Acetylcholine itself hits both muscarinic and nicotinic receptors pretty hard. But then you have a drug like methacholine, which is very picky. It only acts on muscarinic receptors and completely ignores the nicotinic ones. Carbachol, on the other hand, hits both but prefers nicotinic. And bethanechol is like methacholine, sticking to the muscarinic receptors. This selectivity is everything. It's what allows us to use these drugs as precision tools in medicine.
So how does this play out in the clinic? Well, if we want to stimulate muscarinic receptors using an agonist, we can do things like treat glaucoma with pilocarpine or help with urinary retention using bethanechol. On the flip side, if we want to block these receptors with an antagonist, we have a ton of options. Atropine is used before surgery, aprotropium helps open the airways for people with asthma, and thanks to that receptor selectivity we just talked about, we can get even more targeted. Darafenicin can treat an overactive bladder because it's selective for the M3 receptors found there. Pyrinsapine can cut down on stomach acid because it targets the M1 receptors. It's pretty amazing stuff.
And by the way, ever wonder where the name muscarinic even came from? It comes from this, the Amanita muscaria mushroom. This fungus is packed with a chemical called muscarine, which is a powerful muscarinic agonist. If you eat it, your parasympathetic system goes into total overdrive. It's a perfect example of a potent cholinergic toxin found right in nature. Now, we talked about how physostigmine can temporarily block the cleanup enzyme. But there's a much, much darker side. Irreversible inhibitors. These are things like organophosphate nerve agents. Their mechanism is terrifyingly simple and effective. The nerve agent finds the ACG enzyme and binds to it. But instead of just blocking it for a little while, it forms an incredibly strong, stable chemical bond.
This process basically breaks the enzyme, knocking it out of commission not for minutes, but for hours or even days. The result? Acetylcholine levels just build and build and build, completely unchecked, leading to a catastrophic overload of the entire system.
And I need to be clear, this is not just some theoretical chemistry. This is the grim reality of chemical warfare. When you see images of hazmat teams responding to an attack, this is the pharmacology they are dealing with. It's the lethal potential of irreversibly hijacking the cholinergic system. Understanding this mechanism is, quite literally, a matter of life and death.
So to round things out, let's briefly touch on drugs that target the nicotinic receptors. The most famous one, of course, is nicotine itself, a powerful agonist with complex effects. But we've also developed some clever drugs, like varenicline, used to help people quit smoking. It's what we call a partial agonist. It gives the receptor just a little bit of a nudge to reduce cravings, while at the same time physically blocking real nicotine from binding if someone relapses. And then there are ganglion blockers, but they're not used much. They're like a sledgehammer. They block both the sympathetic and parasympathetic systems, causing widespread, messy, and unpredictable side effects.
So, when you step back and look at the whole picture, this single chemical system can be manipulated by a mushroom, hijacked by a nerve agent, and even attacked by our own bodies. It really makes you think, and it leaves us with one final big question. What does the profound vulnerability of this one system tell us about the truly delicate, unbelievably precise chemical balance that is required for every single movement we make and every single breath we take?